You're special.
Okay.
Special.
So Rob, you're
That's
on.
what I say.
We're good to go?
We're good to go.
All right, perfect. So before I dive in, I'd like to kind of know who my audience is. So you guys, you probably all know each other or see each other. I know sometimes I go to meetings, I don't know everybody in the meeting. Can you tell me what you do and where you work?
I am a case manager on the main floor.
I'm Shelby. I'm an RN on the main floor as well.
And by main floor, what does that mean?
Med surge.
That's it, okay, thank you.
My name is Keith. I'm a fourth-year pharmacy student down here on rotation. I'm listening to a little bit of heart failure education. So.
And Donna, education.
I'm Katie, charge nurse in the memory care unit at Helen Porter.
Sweet.
I'm Diane, I'm the 3 to 11 supervisor over at the rehab center. Debbie Blue from lab and IT.
Lorraine, I'm from education at Helen Porter.
Okay, cool, great.
Sam, I'm the professor.
Oh, great, thanks, Ed. How are you? Perfect. So, it all says it up there. My name's Robert. I'm a nurse at the hospital in Burlington. My job is a heart failure clinician. So what I do in Burlington is basically, my job is to push the needle about heart failure with patients and also with staff, to really get people to better understand what heart failure is and how to really get patients to commit to making lifestyle changes, getting patients to understand the importance of taking their medications, and getting patients to understand that this is a really severe disease, and if we don't manage it correctly, it can really shorten your life. So, today's agenda, we got about an hour, so we got a lot to fit in there, but I'm open for questions. Just throw them out, we'll answer them, we'll go down that direction for you. But what I really want to do is take a little time. Research shows that people who don't understand the concepts of heart failure are less likely to teach heart failure. And the problem is we are the forefront of people who are going to educate our patients. So I'm going to take a little time to just provide a little foundation of what heart failure is, the different types of heart failures, more importantly, how we educate patients about heart failure, the little nuances, tricks, certain concepts that really help patients kind of latch onto the concept. And then we're going to really talk about ways to talk about fluids, salt, the importance of daily weights, signs and symptoms, and why we do all those things. And then we'll be done. We got a couple of fun case studies at the end, just to kind of tie everything up in a nice now. All right. We won't really be diving too heavy into medications. There are a lot of great medications out there, but we won't do too much of that today. All right. Here are the facts. Now, heart failure is a big thing, and it's a huge buzzword in healthcare over the last couple of years due to our reimbursements being tied to our heart failure readmission rates. And it's only going to get worse. And by that, more and more patients are going to have heart failure. Currently, about 5 million patients have heart failure. Now, here's a question. Are we, some of us here, predisposed to have heart failure? Is it genetically in us to have heart failure? It is actually a secondary disease. So heart failure is a byproduct of something else. So none of us here in this room are predetermined to have heart failure. But for example, my mom and dad have a cholesterol of 300. Well, guess what? I have a cholesterol of 300. So I am predisposed to have high cholesterol. And that can cause me to have a heart attack, okay? And that heart attack causes that heart failure. Now, if I manage my cholesterol and I never have that heart attack, I never get heart failure. Same thing with high blood pressure. Some patients have high blood pressure. Well, if we don't manage that high blood pressure, well, then that puts a burden on the heart, which then could eventually lead to heart failure. But heart failure is always a secondary issue due to a primary cause. So really, if we really insure patients and tell them, hey, let's manage this hypertension, let's manage this cholesterol, we can maybe one day lower that. Unfortunately, the projections don't say we're going to do that anytime soon. About in 2030, which is not really that far away. I mean, 13 years from now, 8 million Americans will have heart failure. 1 out of every 33 people. 20%, 6% of the population will be over 80. This one scares me the most because I just turned 40 over the weekend, and 1 in 5 Americans will develop heart failure. It's really scary. That's going to be a huge emphasis on inpatient and outpatient, and we're really going to be the foundation to help people understand this. Now, what we do here, the education we provide, pays off. So, at the hospital, I've been doing my job for about 2.5 years now. And when I started this job, educating the staff, educating patients, our readmission rates at the hospital were 21%. As of last month, our readmission rates are now 14%. And that's primarily through education. And it really pays off. It's really getting that patient to understand why we're doing it and what they can do to make the huge difference. It makes a huge benefit. All right. I promise there won't be a lot of school here, but I want to just start the level here with everything. So we'll take 2 minutes to feel like we're in nursing school or pharmacy school, and we'll go from here. So this is the heart, all right? Blood comes into the heart, and we call it blue because it doesn't have oxygen in it. It goes up into the right atrium, gets pushed into the right ventricle. That then gets shot into the lungs. The lungs make them really happy, and everything gets all nice and red now because it's got oxygen in it. It comes back into the left atrium, and we get moved over to the left ventricle, and then that squeezes it out into the body. So the left ventricle is the largest muscle in the heart because it has to be. It's the one that squeezes the blood out of the heart into the body. All right. One last school question. What is cardiac output?
Stroke volume and
Stroke, you're right on. There's one section more. Stroke volume and
Right?
rate? Is that what I heard? Yeah, heart rate. Yeah, exactly. This is the concept of heart failure, all right? So I want to show you a video right now. Kind of sets the tone, and this is one way we educate patients. So our population of heart failure patients is what? 60, 70, 80-year-old patients. I want to give them a tool that makes sense to them. So oftentimes we talk about the I Love Lucy scenario, and it really pays back to what heart failure is all about. Besides Phil Mickelson.
I'm Karen. I'm a teacher. My psoriatic arthritis caused...
What are you doing up here? I thought you were downstairs boxing chocolate. Oh, they kicked me out of there fast. Why? I kept pinching them to see what kind they were. This is the 4th department I've been in. Oh, I didn't do so well either.
All right, girls. Now, this is your last chance. If one piece of candy gets past you and into the packing room unwrapped, you're fired.
Listen. Oh, this is easier. Yeah, we can handle this, okay?
Foundation of heart failure.
What are you doing up here? I thought you were...
About that. And for patients, when you kind of talk about that, hey, your heart's Lucy. And that chocolate, well, that's the fluid in your body. And if we can control that chocolate, or the fluid by managing how much you drink, watching how much salt you eat, that cottage cheese, that hot dog, that bowl of soup, they all have a lot of salt. And why is salt so bad? What was that?
Makes you retain water.
Exactly. And that's a kind of a shocking statement that we all take for granted. And most patients don't actually understand that. They just don't know what salt. They often say, salt dries me out, when in truth, it causes you to retain more water. So if you can get that concept across to them that, well, if we can control your fluid and your salt, that conveyor belt goes nice and slow. And just like Lucy, your heart can keep going. But if you're at home doing those things of eating salt, drinking fluid, well, that's when that conveyor belt starts to go. Go ahead.
I have a quick question.
Yeah?
I've heard people say, if I add extra salt, all I have to do is just I have to drink more water that day. Is that true or is that not?
That would be not true,
That's what I
because
thought.
salt acts like a magnet.
Mhm.
So the more salt you eat, the more fluid you will retain.
So it's really actually not good to be like, oh, I'll just drink extra water today.
It wouldn't be an issue if you didn't have heart failure.
Yep.
But when you drink more fluid and you have more salt in your body, you're gonna be retaining more fluid and get into trouble. Okay? So, by the cardiac output is really the foundation of heart. So, when the heart can't work.
Question before you move
Yeah.
on. What's the relationship between how much salt you eat and what your sodium level is?
You mean like your serum sodium?
Uh-huh. Because people, your sodium level doesn't go way up if you eat salt. Because your kidney controls for that, doesn't it?
Right, and so people with kidney failure often have a higher salt restriction, so they'll go home on like a 3-gram salt restriction versus a 2-gram salt restriction. But you'll often hear patients say, I got admitted and my sodium was 120. I can eat salt, but they're not realizing the whole factor of fluid. So think about this. If I've got this little tiny cup and I pour 1 teaspoon of salt in here and fill it up with water, it's going to be really salty, okay? But then I take a gallon of water and I take that same teaspoon. It's the same amount of salt, but now I put it in a gallon and I shake it up. Well, there's a lot less salt in that water. And patients are saying, well, the doctor or my labs say I don't have enough salt in my body, but yet they've got +3 pitting edema. So if we take that fluid off, their salt levels will go up naturally just because we're drying them out, as we say. Yeah. Great question. So, cardiac output, it's all about that. And in heart failure, that's the concern. Because when you have heart failure, your cardiac output goes down. Now, our heart is an amazing muscle, and it does some really cool things. So what I'll say is, well, your cardiac output, I'm at the gym working out, I need to increase my cardiac output. So my heart will say, all right, well, let's increase the heart rate or the stroke volume. Now, when it comes to heart failure, that's actually the demise of your heart, because your heart tries to work harder, it can't do that, and then it gets weaker, weaker, weaker. So there's 2 types of heart failure. Well, there's a couple more than that, but what are they?
Systolic and diastolic.
Perfect. What is systolic heart failure? If you had a patient in this room right now, and you had to explain to them what systolic heart failure is, how would you do it?
That's a good question.
Yeah? Well, what do you think? You guys, let's just spitball it out. Let's talk about it.
Well, diastolic heart failure, you get swelling,
Okay.
and with systolic heart failure, you get low cardiac output, right?
Both can lead to swelling, but yeah, there's low cardiac output, yeah.
Is systolic more with your lung, like your lungs and whatnot, and then diastolic more with your extremities?
That's another part of heart failure, and that's where things get muddied. It's not systolic, diastolic, that's more left-sided
Oh,
versus
yes, okay,
right-sided.
yeah.
So left is lungs, right
That's what I
is
was
the
thinking
rest
of.
of your body. Systolic heart failure is what we call a weak heart, one that doesn't squeeze well. Okay, exactly. The pump's not so great. So when we get up at Burlington, you may walk by our floor and you'll see 80-year-old ladies going like this, okay? It's kind of funny for me because I know what they're doing, and when they do that, I get so excited because they understand the concept, okay? So I always say to a patient, I have a normal heart that squeezes fine. And my heart looks like this. It opens all the way up, blood fills in, I squeeze, okay? Now someone who has systolic heart failure, instead of getting that great squeeze, they often just kind of look like this, okay? And so when a patient goes, I go, well, what's wrong with your heart? And she goes, this, I know what she's talking about. And it's a good way to talk to them about it. So if someone has a weak squeeze, well, how could that happen? What causes that?
Mitral regurg or aortic stenosis?
Yes. Yeah, that's one of them. What's another one?
Enlarged heart?
Well, large heart is systolic heart failure, but that can be due to a heart attack.
Oh,
Yeah, heart attack is the #1 reason for it, about 66%. So, pump's a really good idea. That's one way to teach it. You know, the whole Lucy thing is another. Another concept we use are water bottles. So this is your heart, okay? And in a normal heart, we fills up with water and we can squeeze it right on up, okay? Perfect, good. Now think about it. When you have systolic heart failure, you don't have that great squeeze, okay? So instead of a full fist, you got 2 fingers. You still got that full thing with water in it, but instead of having that big squeeze, you just get 2 fingers. And when you squeeze it, you don't get as much to come out. So just another way to teach people about it. That's another concept, okay? Now you talked about valves, and that's a really key point because valve issues can lead to heart failure. Why do you think that happens?
The heart's working harder to pump the blood around.
Right. Going back to that cardiac output. So if you have a valve issue, well, guess what happens? Some of the water goes up, but some of it goes out, okay? Now your cardiac output goes down because you're not getting all that blood out. It's going back into the heart. And when that happens, well, then your heart says, I gotta increase my heart rate, or I have to increase my stroke volume. And what happens over time, your body needs more oxygen, more heart muscle dies. And when more heart muscle dies, your squeezing functionality goes down. So just some different concepts for you. All right. I paid a lot of money for these pictures, so I gotta show them, all right? Gotta get a little time. So this is a normal heart. Take a look at this muscle. It's nice and thick, but not too thick. This is the biggest muscle in your heart because it squeezes out into the body, so this is considered nice and normal. Now, if someone's had a heart attack, this muscle has gone to sleep or has died, it becomes a lot more bigger, the squeezing functionality gets worse. We kind of talked about this: cardiomyopathy, coronary artery disease, valve disease, arrhythmias, that dreaded AFib. If you have AFib and a heart failure, that's a recipe to get you back to the hospital really quick. Especially if your heart failure is okay, but you're in AFib and you're at 160s, you're going to be back in the hospital really fast. What is AFib?
Your heart's pumping at different rates, like it's a little fast.
Yeah. You know, a normal heart, top squeezes, bottom squeezes, top squeezes, bottom squeezes. In AFib, you just quiver and squeeze, quiver and squeeze. So when you're in AFib, you lose that kick of pushing blood into the bottom part of your heart. It kind of just gravity gets it in there. So it makes it harder for the bottom part to fill up. And if you have a poor squeeze, now you're reducing even more of the fluid that gets out. So AFib's really bad. We want to control that rhythm, get them feeling great. All right. Ejection fraction. Now, as a cardiac nurse, all my life, when I see an echo, the first thing I run to is to see what the ejection fraction is. That means the world to me. And as a heart failure clinician, I've realized that's only half the story. And that's something we want to make sure we understand, that the EF is great, but when it comes to diastolic heart failure, the EF doesn't really mean much. Okay? So an ejection fraction is just the amount of blood pumped out of the ventricle over the total amount of blood in the ventricle. What's a normal ejection fraction?
65.
Yeah, 60 to 65. If I took everyone's average in this room, we're all probably about 60 to 65. Now, in all honesty, as long as it's greater than 50%, we consider it to be normal. And that's kind of an important thing to tell a patient because we all come from the world of grading, where we want 100% on everything, okay? We're all type A people here. We all went through nursing school, pharmacy school, some sort of grad. We all want good grades. And most people understand 100% is what we're shooting for. So if you can set that expectation, well, that's not so bad if you hear, oh, I'm 60%, I'm doing just fine. Now, 40 to 50 is considered the middle world, where we classify you as heart failure, and we treat you like you have heart failure, but it's kind of the gray world of heart failure. And anything less than 40% is considered heart failure. Okay? So if there's systolic heart failure, well then there's diastolic heart failure. And what is diastolic heart failure?
The filling of your heart, where it doesn't fill in enough, or your heart, right? It's
You're
something not
correct.
filling.
Yeah. All right. I jumped ahead too fast. So one last thing about systolic heart failure. So this is the demise of the heart. So your heart isn't squeezing as well. So to get that cardiac output up, it begins to work harder. To work harder, your heart needs more oxygen. Well, the problem is your heart's not pumping so well, so it can't keep up with the oxygen requirements, so more muscle cell death. And that EF that was 30% now becomes 25%. All right? Now to diastolic heart failure. You're 100% right. Diastolic heart failure is the muscle growth in the heart. It causes the muscle to become less flexible. Back to that arm thing, okay? So a normal heart opens all the way up, it squeezes, opens all the way up, and squeezes. When someone has diastolic heart failure, the muscle is getting larger. It's kind of like when you go to the gym. So I go to the gym to work out. Not very well, but I do. And I try and build muscles, okay? And that's a good thing. But the problem is when your heart's working harder than it needs to, fighting against hypertension, maybe fighting against lung issues, well, it builds muscle to hopefully work harder. Now the problem is when it builds muscle, it's kind of like those guys, when you walk through the grocery store, you see those magazines with those big muscle guys, okay? And those muscles get so big, but they can't really move, they're not very flexible, and that's what happens to the heart. So instead of opening all the way back up again, when that muscle gets bigger, it may only open halfway. So instead of getting a full cup of blood, your heart only gets a half a cup of blood. Now, you're super excited because you look at the echo and you're like, sweet, this person has an EF of 60%, we're golden. But then you read on and you see that they have mild left ventricular hypertrophy. So what that means is that they're starting to show signs of diastolic heart failure. So even though they have a great squeeze, the problem is they're not getting a full cup of blood. So instead of opening all the way up, they get a half a cup of blood, and now they're only squeezing 60% of that half a cup of blood. So it reduces the amount of flow. So think about this. We got a balloon, okay? Now in a normal heart, when I have a balloon, and I need to work harder, I'm running, a bear's chasing me on the long trail, I can work harder. So it can expand. All right, I'm doing more work, I'm getting more strenuous. It can expand more. And that's the beauty of our heart. It's elastic, it can accommodate for what we need. But when you have diastolic heart failure, well, instead of being able to, accommodate for things, your heart is kind of rigid, almost like a cup. So in heart failure, when you have diastolic, you get that thing, you're working out, you're doing a lot of activities, and your heart needs more. But because of the muscle, you can fill it up, and it fills up, but it can't accommodate anything more. So eventually, it just overflows. And that's the problem with diastolic heart failure is we don't have the ability for the heart to expand and to accommodate. Kind of back to the water bottles, the issue here is you got that water bottle, and instead of being perfectly filled up like it was in systolic, well now, you only get a little bit of water in that chamber because the chamber's a lot smaller. But you've got an awesome squeeze of 60%. But the problem is there's not a lot of water in there, so even though you have a great squeeze, you can't get anything out because it just doesn't have a lot of volume in it. What causes diastolic heart failure?
Back to the valves.
Valve, for sure, yeah.
AFib.
Myocardial hypertrophy.
Yeah.
Heart attack?
Heart attack, not as much. That's more of a systolic because it's causing cell death. But hypertension can be one. Yeah. So think about that. Our hearts, in the normal world, our arteries look like this. Really easy, blood shoots right through them, life is great. But when you have hypertension, you go from this to this. And your heart still has to push all that blood, but now it's going through this little tiny straw. And to be able to get over the resistance of that straw, your muscle gets bigger. And that's why it becomes harder, and the muscle gets bigger and bigger and bigger. Now, I come from a cardiology world, and not to say I ever want a heart attack, but if I was to have a heart attack, I want a non-STEMI over a STEMI. Why?
Heart infarction.
Right. It's a better heart attack, better recovery. Now, when it comes to heart failure, between systolic and diastolic, our pharmacy people will say there are a lot of great medications out there for systolic heart failure. Some things that have come on the market right now that are showing some great differences. In regards to diastolic heart failure, once that muscle starts, we can't reverse it. Our goal is to not get it worse, okay? So think about that. And I can give you medications. Your EF can go from 40 to 45 to 50. But in diastolic, if you have medium or moderate left ventricular hypertrophy, our goal is not to get that to go away. Our goal is to make sure it doesn't go too severe. And we do that by diet, salt, fluids, and if there's a blood pressure issue, managing blood pressure.
So
All right.
how do you diagnose diastolic heart failure?
Same way as you do systolic through an echo. You'll be able to notice that the echo will tell you what's going on.
What does echo say? Is it like a pulmonary hypertension or?
Pulmonary hypertension can cause diastolic heart failure, but it's not a universal statement. What it will say is, for example, it will say, for systolic heart failure, you'll focus on the left ventricular, and it'll say an EF of 25%.
Right.
For diastolic heart failure, it may still say a low EF,
Uh-huh.
or it may say a normal EF, and then it may say moderate. For me, up in Burlington, it says a moderate LVH, severe LVH. It also may say left atrium dilation, moderate dilation, or right atrium dilation for it. So that's how it will usually come through.
So when you see dilation or hypertrophy or something to tell you if the heart is getting bigger,
Yes,
then, okay.
yeah, that's a sign of diastolic heart failure.
They actually measure the thickness of the wall of the myocardium.
That is correct. So that's the key, because we always hone in on that EF, that 40%, 50%, 65%. And we get really excited and say you don't have heart failure because you have an EF of 60%, only to see that they have diastolic heart failure. All right, once again, paid big money, so I got to show it to you. So normal heart muscle is kind of like this, all right? Now notice in diastolic heart failure, there's a stiffness. This muscle is getting a lot bigger, and what's happening to this chamber? Smaller. Very hard. This doesn't go away, even if we get you on the right meds. We just want to make sure it doesn't get worse. Perfect. Causes of diastolic heart failure. You guys kind of talked about diabetes, valve issues. There you go. Blood supply. So diastolic heart failure reduces the amount of fluid we can push out because we don't get a lot of fluid in that chamber, even though we have a great amount of muscle. So, well, we say, well, we got to improve the cardiac output, let's improve the stroke volume, let the muscle get bigger. Well, to grow muscle, you need oxygen. So to increase your oxygen, your heart has to work harder. It can't work harder, so then more cells die, and then it gets harder and harder. It's this vicious cycle. Your heart thinks it's helping itself, but in the long run, it's hurting itself. And that's why medications are so important. Your beta blockers, your ACEs, your diuretics, all help to minimize and reduce the cycle from happening. All right, what puts you at heart risk for heart failure? We already talked about a couple, one being heart attacks or cholesterol, hypertension. What are others?
Sedentary lifestyle.
Yeah,
Smoking.
definitely.
Getting older.
OSA.
Yes, OSA, yeah. There's some interesting research about OSA lately, but we won't go into that.
Oh.
Family history is the big one.
Yeah, another issue is me, or not me, but me as a person, males. Yeah. My wife may say me, but age, male, hypertension, myocardial infarction, valve disease, obesity. So, a couple of things here to point out. Obviously, we know about the smoking, all these sleep disorders, but excessive alcohol consumption and drug abuse. The world we live in right now, these are realistic issues. We have a heroin issue here, we have people who are doing that, they're going through their valves. These are questions you want to ask. So if you have a 25-year-old male who's coming in with heart failure, a realistic question to ask is, what do you do in life? Do you party a lot? Because that can be a key insight into what's going on. All right, assessment. Chest x-ray, EKG, echoes, labs. We talked about the echo, how it determines systolic versus diastolic. I'm having a loose lip here today. What's BNP? A troponin tells about heart damage. What does BNP tell you about? Heart failure, yeah. So, you're in a room with other nurses and they want you to explain, so his BNP level is up, he has heart failure. What does that mean? Like, why does the BNP go up when you have heart failure? That's a great question. So, a normal heart, assuming all of us have normal hearts, is less than 100. Someone who has heart failure is theoretically greater than 400. you will see patients who come into our emergency room whose BNP is 21,000, 50,000. What it is a sign of your heart being overwhelmed by fluid. It's the actual stretching of the heart. And when your heart stretches, it releases this enzyme. When I explain that to a patient, she's like, oh, it's like when I drink a lot of fluid and my jeans start to stretch like that. I said, kind of it is, you know? It's the body stretching, and when it stretches, the heart releases this enzyme.